golden opportunity, like all young respiratory therapists, they are just joined in the first year or maybe interns, or maybe they finished the respiratory therapy bachelor degree and they are practicing across India or outside, so they can utilize this golden opportunity to learn from the experts. So particularly who are involved in caring the critically ill patients. So today we have one of the eminent speaker, Dr. Rishi Katiyar, who is a consultant in the Department of Critical Care and Anesthesia from Apollo Hospital, Bhopal. Welcome, Dr. Rishi. So, moderator Sulochana Kumari, she is the head respiratory therapist in the Division of Respiratory Therapy and Department of Critical Care Medicine, Bharati Hospital, Pune. So she is going to moderate the session. So at the end of the session, we'll take the questions in an interactive way. So from the students or delegates who are attending this fantastic lecture series. So be involved in like getting cleared your doubts so that you can apply the things at the bedside. Suppose my suggestion is like someone who is not able to interact in this session. So when they attend the next session, because it's a series of lectures will be there, they can carry their doubts and they can clarify with the next session expert also. With that idea, we'll hand over the session to Akash. So he's going to introduce our moderator and we'll open the session. So thank you all the very best.
Thank you. So hello everyone and a very warm evening. I now hand over the session to Sulochana, who's our moderator of the session. She will introduce Dr. Rishi and his background, and soon we will start the session. Thank you.
Before that, I just request Saumi to speak to a few words on the plan. Saumi, over to you, so that we can proceed further.
Yeah, thank you, sir. You have welcomed everyone in a very warm way. So, we are very happy to have a collaboration with Hamilton, which is an international firm, which is known to everyone in for their education and very cooperative way of communicating with clinicians like us. So, we are very much excited to have the first session today. Without further delay, I will just request Sulochana to start.
Good evening, everyone. I am Sulochana. I'm in charge of Division of Respiratory Therapy at Bharati Hospital and Research Center, Pune. On behalf of IRC and Hamilton Medical, I warmly welcome you all to the first session of our webinar series. Today's topic is common modes of ventilation. It's a fundamental yet critically important area in respiratory care and critical care practice. Understanding ventilation modes is essential not only for optimizing patient outcomes, but also for ensuring safe and effective use of modern ventilators in diverse critical care scenarios. It is my privilege to introduce today's esteemed faculty, Dr. Rishi Katiyar sir. Dr. Katiyar sir is currently serving as a consultant at Apollo Sage Hospital, Bhopal. He has completed his MBBS from MGM Medical College, Indore, followed by DNB in anesthesiology from St. Stephen's Hospital, Delhi. He further pursued PDCC in critical care medicine from AIMS. And in addition to this, Sir holds several distinguished qualifications, including EDIC, FCRS, FCCU, ICARE, reflecting his deep commitment to excellence in critical care. With his expertise and hands-on experience, Dr. Katiyar sir will guide us through the commonly used ventilation modes. So let's join together in welcoming Dr. Rishi Katiyar sir. Over to you, sir.
Thank you, Sulochana, for this kind introduction. Without wasting much time, I'll straight away go to the presentation. Hope I am audible. My voice is not getting cut and it's audible.
Yes, sir.
Yeah. So I'll share my presentation. Hope my screen is visible.
Yes, sir.
Akash?
Yes, sir. Yes, sir. It's visible.
Yeah.
Yes, sir, it's visible.
So good evening all. Today, this session, as you already know and Harish sir has introduced, we are going to cover one of the most fundamental skills in the critical care and emergency settings. This is regarding the understanding and using of basic modes of mechanical ventilation. This is a life-saving tool, and at times troubleshooting effectively and managing these skills require a solid grasp of both physiology and practical applications during this session. We will navigate through basic modes of mechanical ventilation. What are the basic modes of mechanical ventilation? How these modes operate? We will also go through some real case world scenarios. Along with it, with the help of Hamilton, we'll be using the Vent Trainer app, which is a real-time simulation app, to understand better about the practical application of these modes through the Vent Trainer application. So basically, the first mode is the basic modes of mechanical ventilation is the evolution of mechanical ventilators. How do these ventilators evolve? We are commonly used to use the volume control mode, the pressure control modes, and further evolution into the dual modes, by which are the advanced modes in the mechanical ventilation. So basically, if we are talking about the mechanical ventilatory modes, what does a ventilator do? Why do we need a ventilator for our patient? So basically, in simplified language, to provide oxygen to your lungs and to the body, simply in case of hypoxia, to remove excess of CO2 which is built up in case of hypercapnia, and to keep the lungs open provided the lungs are collapsed due to any of the etiologies, maybe pneumonia, consolidation, or due to any neuronal loss of control that may lead to loss of your respiratory control. So providing ventilatory supports in these three settings are the basic settings in which ventilatory supports are to be provided. Now, to understand any mode, or any mode has to be understood on the basis of three things. Whenever we are connecting a ventilator to the patient, ventilator assesses the patient. There are certain things which a ventilator does. First and foremost, to initiate the breath to this patient, there should be certain trigger. Trigger is what? Trigger is something, a variable which is involved in initiation or triggering of inspiration. That means what is the stimulus which will lead to initiation or triggering of inspiration? Now, how does the ventilator sense whether that this breath has to be initiated? So either it will be a pressure trigger, a flow trigger, a volume trigger, or a time trigger. So depending on what trigger we have selected or what mode we are using, the trigger may vary. Second is the limit. The value of this variable cannot be exceeded at any time during inspiration. So when the ventilator starts giving a breath, the flow starts from the ventilator. What is the limit? It may be a pressure limit which we have set, an upper pressure limit which has been set during inspiration. So it will be the pressure limited ventilation. If we have set a volume limit and the inspiration won't exceed apart from giving whatever the volume which we have set, and it will be a volume limited ventilation, or it would be a flow limited ventilation depending on the mode. Like in a volume control mode, flow is a limit variable. Then comes the cycle. Now, what do you mean by cycle? The cycle means that the variable which is used to end inspiration and start expiration, to cycle off from inspiration to expiration. Now, what it does is the ventilator cycles from inspiration to expiration if it is given certain amount of volume, or you have set a particular time, or it has reached a particular percentage of the peak flow or a pressure. So this may be a cycle variable. So depending on these three variables, what happens is the modes are classified into volume targeted ventilation, pressure targeted ventilations, or the dual control ventilations. Now the dual control ventilation, the volume targeted ventilations means they are targeting certain amount of volume which has to be given to the patient. Now this volume could be a volume assist control ventilation, or it would be a volume synchronized intermittent mandatory ventilation. It will be a pressure targeted ventilation limited by the pressure. We have set a particular pressure, so pressure controlled ventilation or a pressure support ventilation. If we are taking the advantage of both the volume target as well as the pressure limited, then it may be a dual control ventilation. So it may be a pressure control ventilation or a pressure support ventilation. So these are the basic modes which we'll be studying today. Without wasting much time, let's start with the volume targeted ventilation. So what actually is a volume targeted ventilation? Volume targeted ventilation, as the scalars are showing over here, the scalar is that anything which is plotted against the time. So in the first curve, we are seeing that there is a flow which is plotted against the time. Second curve, the pressure is plotted against the time. And the third curve, the volume is plotted against the time. If we are targeting a volume targeted ventilation, maybe a controlled mandatory breath or a assist control breath. The difference between a assist control or controlled mandatory breath is, in mandatory breath, all breaths are triggered by the ventilator. It is a time triggered breaths. In assist control mode, the patient may have the liberty of triggering the breaths in between. So the ACMV mode ensures that the physician determines the tidal volume and the respiratory rate according to the need of the patient. So as we are seeing in this curve, the volume targeted ventilation, particular amount of volume is selected and it is constantly given to the patient. Once it is constantly being delivered to the patient, the ventilator ensures that whatever volume which you have selected goes into the lungs of the patient. Now, it may happen that the variables of the lung, that is compliance, the elasticity of the lung may vary, resistance of the lung may vary, but the ventilator will continue to deliver the set tidal volume to the patient. So this is the volume targeted ventilation. Now, depending on the mode which is selected, it may be an assist control mode or a SIMV mode, which is volume targeted. Now, the advantage, before going further to the slides, again, I would request that we practice this volume targeted ventilation and demonstrate this volume targeted ventilation on the vent trainer mount. So I would request Sulochana, if you can share your screen about the vent trainer application.
Yes, sir. I hope the screen is visible.
Yeah, it is visible. So whenever we are setting a ventilator, certain inputs are to be given to the ventilator. What type of patient? If it is an adult patient, child, or a neonate, so we select an adult patient, select the gender of the patient, maybe a male patient, an adult patient, select the height of the patient. So basically the height is needed for calculation of the ideal body weight of the patient. So we have selected a 170 centimeter male patient, which has got a calculated ideal body weight of 66 kgs. This patient is a passive patient. It has no active efforts, is being electively, we tend to ventilate this patient on CMV mode, that is mandatory minute ventilation, the fixed volume ventilation with no active efforts. So just select the CMV mode for this patient. Right. So whenever we are selecting the CMV mode, there are certain variables which are coming on the ventilator, which we need to input. As I told that we have to select particular amount of tidal volume, which has to be delivered. So just select a tidal volume to be around 7 ml per kg. Maybe around, 6.9 ml, that is 7 ml per kg. Select the respiratory rate of around 14. this is basically we want to ventilate this patient. This is a post-operative patient, so we want to select a respiratory rate of around 40, PEEP of 5, FiO2 of 50%. Flow pattern has to be changed to a square wave pattern. In certain modes, there this flow pattern is fixed. In certain, we have to select the flow pattern. The flow pattern should be, yeah, this is the flow pattern which has to be selected. Now we adjust the I/2 ratio to 1:2 by selecting the inspiratory time. So adjust the inspiratory time to keep the I/2 ratio around 1:2. Yeah. Yeah. So now when we have selected, we have introduced these variables which we have input in the ventilator. This is the respiratory rate, the fixed tidal volume, the PEEP, and the FiO2. And depending on these variables, we are seeing certain scalars which are being displayed on the ventilator. So first scalar is the pressure time scalar, in which there is a peak pressure which is going over here. Then the flow pattern, if we are seeing that there is an inflow where a constant flow is achieved, and then there is a cycling to the expiratory part. Volume, as we are seeing in the volume time scalar, there is a fixed volume which we have selected of 460 ml, which is going in each breath to this patient, because this is a volume targeted ventilation. So each breath is of 460 ml. So 14 breaths we have selected. These 460 ml of 14 breaths will be going to the patient. Now, the disadvantage of this mode is, now first and foremost the advantage. So advantage is we are maintaining a good minute ventilation. The patient is, if we want to wash out the CO2 of this patient, we maintain a good minute ventilation, and this mode will be helpful in washing out the CO2 and maintaining a good minute ventilation of this patient, allowing rest to the respiratory muscles, as there are no inspiratory triggers. There is no inspiratory trigger which is seen in the pressure time scalar. No triggering is seen in the pressure time scalar of this curve. Now what happens is, suppose the same patient which was being ventilated suddenly develops a ventilator associated pneumonia on day 3 or day 4 of the ventilation, and the lung compliance goes down. So if the lung compliance, that is the rate of change of volume with the rate of change of pressure, that goes down, and the patient develops pneumonia. So what happens is, this static compliance is now started coming down. Now, once the static compliance is coming down, we have instructed the ventilator to ventilate the same lung with 460 ml of tidal volume, because it is a volume targeted ventilation. So it will continue to give a fixed tidal volume of 460 ml. No matter the peak pressures, they start rising up and continue to rise still to 450. Now it is trying to give 460 ml, not able to give 460 ml. Why? Because it has reached an pressure limit, upper pressure limit of 40, which is displayed in the red, and an alarm of high pressure is coming. So what is it is depicting? That ventilator is being instructed to give a fixed amount of tidal volume. If the compliance of the lung goes down, still the ventilator continues to give a breath of 460 ml, depending on whether we have selected a pressure limit accurately or not. If we have selected a pressure limit, then it won't exceed that pressure limit, but still will continue to give this 460 ml of tidal volume. So this, here comes the disadvantage of volume control ventilation. In low compliance lungs, especially in ARDS, using volume targeted ventilation like VCV or CMV may compromise the inflation of the lungs, as it may cause barotrauma, indicating that the same tidal volume which has been selected is being delivered to this patient. So this is regarding the disadvantage of this. Now we come out of the again vent trainer mode and go ahead with the other modes. So this was regarding the volume targeted ventilation or the assist control mode of mechanical ventilation. So the volume targeted minute ventilation is guaranteed. The set tidal volume is guaranteed. Patient can choose to overbreathe the set respiratory rate. Each breath is delivered in synchrony with the patient's spontaneous efforts. This makes the breathing comfortable. The mode of the effort rests to the patients and unloads the respiratory muscles. Disadvantage is also of the same, that because of the prolonged unloading of the respiratory muscle, it may lead to atrophy, sedation, and paralysis. Both are required for abating the efforts of the patient. The work of breathing at times may be high if we have not selected the trigger sensitivity. Right? So airway pressures may rise if lung mechanics are poor. Dynamic hyperinflation can occur. The breathing schedule is relatively rigid. That is, we have set our respiratory rate, we have set our tidal volume. Alkalosis may occur if the set respiratory rate is too high and the patient continues to be ventilated on the same tidal volume. If the lung compliance was poor at the time of initiation and the lung compliance improves, the set tidal volume will continue to being delivered, but the peak pressures would come down. I think somebody has messaged in the chat box that there is some doubt. So we'll be dealing with the doubts at the end, or in between we can take the questions.
So I think we will take it at the end of the session, sir.
Yeah.
Yeah.
So this is regarding the volume targeted ventilation. Other volume targeted modes like synchronized controlled mandatory ventilation, which we have already seen in the vent trainer scenario, synchronized intermittent mandatory ventilation, adaptive pressure control modes, APMV, adaptive pressure ventilation with synchronized intermittent mandatory ventilation. Now, as I had started my lecture with the three mandatory things, that is trigger, limit, and cycle. We are through with the volume targeted ventilation, in which the trigger, if it is a CMV mode, the trigger is time, limited by flow, and cycled by volume. We have set a particular volume. When the volume is delivered, it will cycle back to expiration. If the patient is having certain amount of efforts, that is an assisted mode is there, assist control mode, ACVC mode, which we commonly say. So in that, the trigger may be time or trigger may be patient, right? So this is regarding the ACVC and VC-CMV mode. Now coming to the VC-SIMV mode. CMV mode, we are already through. Breath can be triggered by ventilator or by the patient. Ventilator always deliver the set tidal volume. Pressure in the airway can increase or decrease depending on the resistance and compliance of the lung. As we have seen that when the compliance of the lung was going down, the peak pressure started rising, ensuring that the ventilator was continuously giving efforts to deliver that amount of tidal volume. To protect the patient's lung, it is important to carefully set an upper pressure limit. As we had already done in the vent trainer, we had set an upper pressure limit of 40. So the volume delivery was restricted as we have reached already the peak pressures of 40 centimeters. Now, ventilator controls, as we already know, for CO2 elimination, we need to maintain a minute ventilation, so tidal volume and respiratory rate. For oxygenation targets, keep up positive and expiratory pressure. To recruit the alveoli, give a PEEP, maintain an IS2 ratio regarding the flow pattern. We have to set up flow pattern for maintaining the oxygenation. For better synchronization, we have to effectively select the flow triggers and the pressure triggers, which we will be again seeing in our coming scenarios. Coming to the SIMV mode, the word SIMV stands for synchronized intermittent mandatory ventilation. Each SIMV breath interval includes a mandatory time, T mandate, and a spontaneous time, T spontaneous. Now the SIMV mode ensures that the set target volume is delivered during the mandatory breath. After the mandatory breath is delivered, the patient is free to take any number of spontaneous breaths for the remainder of the SIMV breath intervals. Now, though these are the settings which we do, that is the respiratory rate. We set a SIMV rate, we set a tidal volume, for oxygenation, we set all these parameters. And for patient synchronization, we set the PRAM, ETS, and triggers. Now, what we are doing is, again, we are going back to the vent trainer mode, and we will be demonstrating the PSIMV mode, that is pressure control, or basically the SIMV mode, before going to the pressure control modes. Yeah. Now we change the mode to SIMV. In volume control adaptive, we change to SIMV mode.
So is my screen visible?
Yeah, it is visible. I think you have paused the waveform. Just unpause the waveforms.
Let me try. Yeah. I think now it's.
Just remove the standby.
Yeah.
So what can you show the controls? What all controls you have set in for setting this APV SIMV mode? Yeah, right. So in this screen, what all variables which you have input is, you have set an SIMV rate of 14, just reduce it to 10. This is the mandatory 10 breaths, which I suppose the ventilator has to deliver. Now, this is the tidal volume of 460 ml, PEEP of 5, FiO2 of 50%. Just go down on the flow triggers. As we have selected the flow trigger at 5 liters, just make it to 2.5 liters per minute. This is the flow trigger which the ventilator will sense whether the patient is taking a trigger or not, taking an inspiratory attempt or not. ETS is the expiratory time sensitivity. We have selected to 25%. We will be discussing it in the spontaneous, when we will be discussing the spontaneous mode of ventilation. Now we have set up pressure support, P support of 15, and adjust the TI at the rate of 10 to keep a ratio around 1.1:2 to 1:1.5. Yeah, just go down. Just go down a bit. Right. This is regarding the mandatory breath. Now, yeah. Okay. Now you can see, just come out of the controller and see the waveforms which are being displayed on the ventilator. So just go to the monitoring and display the graphics. Yeah. So in this graphics, again, it is paused. So in this ventilatory graphic, can you see any triggers? There are no triggers which are there. Whatever rate you have set, whatever tidal volume which you have set, the patient is being ventilated on this. Suppose now this was what the settings you have done. The patient was also having certain efforts which were there. So just make your patient having certain amount of efforts, inspiratory efforts are there in this patient. So Lochna. I think the vent trainer is not getting displayed. Akash, am I audible?
Yes, sir. Yes, you're audible. Just a second.
Just try to again go back to the screen of vent trainer. By the time they are sharing the screen, I will continue with my presentation.
Yes, I think she is getting difficulty to share.
Yeah, by the time she joins back, I will continue with our presentation.
Yes, sir.
So basically the pressure control mode, the pressure next we are going from the volume targeted ventilation to the pressure control or pressure targeted ventilations. Now pressure control modes may be named as PCV plus, PC pressure control ventilation, pressure control synchronized intermittent mandatory ventilation, or spontaneous modes. Now PCV plus mode, breath in the PCV plus mode are pressure controlled and mandatory. The ventilator delivers. Now you are instructing the ventilator to deliver a particular breath at a constant level of pressure. So you are making a constant pressure. You are instructing the ventilator to ventilate or give a breath to the patient at a particular constant level of pressure. So in this mode of ventilation, what will be constant will be the pressure, but what will be varying is the volume, which will depend on the pressure setting, the inspiratory time, and the resistance and compliance of the patient lungs. The flow waveform rises rapidly at the beginning of inspiration. It gives a sudden gush of flow to the patient and followed by a decremental pattern or deaccelerating pattern, decreasing as the pressure decreases. The flow also gets distributed inside the lungs. So it has got a deaccelerating pattern. As I said, it may be a PC-CMV mode or PC-AC mode. PC-AC mode is assist control mode, in which the patient may trigger a breath in between. Limit will be pressure, as you have instructed the ventilator to keep a constant pressure. So the pressure will always be constant. It will be a constant pressure throughout all the breaths, which will be there. The flow pattern, as you recognize it, the flow pattern will be a deaccelerating flow pattern. So it will be a deaccelerating, it will give a sudden gush, and then there will be a deaccelerating flow pattern. It will be cut off and will go back to the expiratory prime. So what is cycling in PC, CMV and PCAC? It is the time cycle. It is time cycled. It will at a particular inspiratory time, it will cycle back to expiration. Now this is time cycled mode, PC CMV mode or PC AC mode. It may be a PC SIMV mode, in which synchronized intermittent mandatory breaths may be given in between. Right? So this is regarding the pressure control. Settings again for CO2 elimination. You go ahead with all the setting the pressure support, setting the rate. For oxygenation, you select the PEEP, I:2A ratio, FiO2. For synchronization, triggers and the P-ramp. P-ramp means the time needed for the pressure to rise to a particular level, right? PSIMV stands for pressure control synchronized intermittent mandatory. PSIMV plus mode, the mandatory breaths are PCV plus breaths. They can be alternated with the spontaneous breaths. So this is PCSIMV. Each, as you already have mentioned, that SIMV breath means synchronized intermittent mandatory breaths means that in between whatever mandatory breaths are being given, the ventilator waits, gives time to the patient for what it gives time for the patient to breathe spontaneously in between. If these spontaneous breaths are inadequate, it is being supported by whatever pressure supports you are giving in between the breaths. So if the patient triggers a breath during spontaneous T-spont, the ventilator delivers a spontaneous pressure supported breath. If the patient does not trigger a breath during the T-spontaneous, the ventilator automatically delivers a mandatory breath at the end of T-mandate. This is regarding the SIMV pressure control. Again, the settings are same. If the patient triggers a breath, the ventilator delivers a breath supported by the whatever pressure support you have set in the settings. If the patient does not trigger a breath, the ventilator automatically delivers a mandatory breath at the pressure control settings which we have set. SIMV mode, advantage, mandatory breath in synchrony with the patient efforts. Advantage, again, mandatory breath, patient can breathe at his preferred respiratory rate, tidal volume and flow. Patient's respiratory muscles remain active and so disuse atrophy is less common. But disadvantage, work of breathing can be high. Hypoventilation is possible. Excessive work of breathing is possible during spontaneous breathing. So this is the reason why SIMV mode is now less used and is being obsolete because of increased work of breathing in the SIMV. Coming to the spontaneous mode. In spontaneous mode, spontaneous stands for SPONT stands for spontaneous. Spontaneous deliver the spontaneous breaths, operator initiated, manual or mandatory breaths. When pressure support is set to 0, ventilator functions like a conventional CPAP. So whatever breaths are being triggered, these are being triggered by the patient himself. Now the ventilator is just supporting these breaths by giving certain amount of pressure support. The PEEP setting which you define is the positive end expiratory pressure during the end of expiration. Now comes the ETS. ETS defines the inspiratory timing of the breath. Now, as I already told, that the spontaneous mode of mechanical ventilation is flow cycle. So what happens is, if you set a ETS, the inspiratory time is being decided. Suppose you have set it to 25%. What happens is, whenever the flows fall from peak inspiratory flows to the 25% of its limit, the cycling occurs from inspiration to the expiratory part. This is in the pressure support or spontaneous mode of ventilation. This is why the spontaneous mode, all the breaths are triggered by the patient himself. These are flow cycled breaths, and the volume may vary depending on the patient's efforts and the pressure support which you have provided. As the patient's efforts start increasing, you go down on the pressure supports, and the patient starts getting his adequate tidal volume on the minimal pressure supports. This is the flow waveform. That is the flow time scalar, the pressure time scalar, and the volume scalar. We can easily see there is a negative deflection which is being deflected over here. That means the negative pressure generated by the patient. So these are the patient triggered breaths. All breaths are the patient triggered breaths. The flow time scalar, if we are seeing that in this flow time scalar, the inspiration is going on, the flow goes to the peak, and as soon as it starts falling and comes to a certain limit, what we have set in the ETS, it cycles back to the expiration. So this is regarding the flow time scalar. The volume may vary with depending on the pressure support. So it is this is a parabolic curve of volume time scalar in the pressure support or the spontaneous mode of ventilation. Advantage: it encourages spontaneous breaths. All breaths are patient triggered, so it reduces the work of breathing. Faster weaning is possible on the spontaneous mode. Now, as we all have seen the advantages of pressure control ventilation, we have seen the advantages of the volume control ventilation. We have seen that when we were targeting the volume selectively for the patient to get ventilated, what was happening was changing the lung compliance and the resistance. There may be chances of barotrauma to the patient. If we are selecting the pressure control ventilation, then we were able to prevent the barotrauma. We were able to provide a lung protective ventilation to the patient. If we combine the characteristics of both these breaths, then comes the role of the dual control breaths. Now, dual control modes in this, the first dual control mode, which we will be discussing about, is the pressure regulated volume cycle PRVC mode. This PRVC mode is a volume targeted and pressure controlled mode of giving breath. It was introduced in the Servo 300 in 1990s. There are synonyms for this PRVC mode in different ventilator companies. There may be Autoflow in the Drager, VC plus mode in the Puritan Bennett, adaptive pressure ventilation in the Hamilton mode, that is C5 and C3. So what I am trying to say is that this PRVC mode is considered an advanced dual control mode or an adaptive mode, because the ventilator uses both volume and pressure to automatically adjust the patient's ventilatory needs breath by breath. So what is happening is the ventilator is assessing the compliance of this patient by checking the plateau pressures, just giving the first breath using the volume control mode. So when the ventilator is giving the first breath in the PRVC mode, that is a volume cycle ventilation. By giving that volume cycle ventilation, the ventilator comes to know what is the plateau pressure of this patient, what is the compliance of the lung of this patient. The next breath, the next volume which will be delivered will be depending upon the plateau pressure in the previous breath which is there, right? So adaptive pressure ventilation, it is a synonym which is in the Hamilton ventilator, similar to PRVC mode. Basic setting parameters will be these, which will be again seeing in the vent-trainer simulation. How it works, the ventilator adapts to the exhaled volume and in doing so assesses the plateau pressures and the static compliance, right? So it finds the correct pressure to deliver the desired volume. Baseline pressure is always constant. How does the PRVC work? A test breath at an inspiratory pressure of 10 centimeter above the PEEP is delivered. On the basis of the tidal volume achieved with this pressure, the ventilator calculates the system compliance. After the ventilator has completed the system compliance, each breath is delivered after calculating the compliance of the preceding breath. The flow and the inspiratory time is automatically adjusted to deliver the targeted tidal volume with the lowest peak inspiratory pressure possible. So for the subsequent 3 breaths, again, it will be calculating the tidal volume depending on the previous plateau pressure in the previous breaths. So not intra-breath, but inter-breath variability. Inter-breath assessment of the compliance will decide the tidal volume which has to be delivered to the patient. This is in the PRVC mode, the inter-breath between the 2 breaths. Subsequent breath, previous breath, the ventilator has assessed the compliance, assessed the plateau pressures, decided about the tidal volume which has to be given in the subsequent breath. This is how the PRVC mode works. Again, it has got a deaccelerating inspiratory flow pattern, which is there. Pressure automatically is adjusted for changes in the compliance and resistance within a set range. Tidal volume, it tries to guarantee, limits volume trauma, and prevents hypoventilation. How? That we will be again seeing through our case scenario. Coming to the volume support mode, it is phenomena volume support mode of ventilation. It is a spontaneous mode where a target goal volume is set on the ventilator. This ventilatory strategy is dependent on patient's spontaneous breathing and triggering the ventilator to support the breath. In the PRVC mode, usually the patient is not having any spontaneous trigger. If it has a spontaneous trigger, it is a synonymous mode which is being there is the VS mode. This is volume support mode of ventilation. The ventilator adjusts the amount of pressure support to deliver each breath. That is, if the patient's tidal volume is greater than the set targeted tidal volume, then the ventilator will decrease the amount of pressure support in the subsequent breath to try to achieve the goal and vice versa. Respiratory rate is not set in this mode of ventilation and is dependent on the patient himself. He himself is deciding what amount of respiratory rate has to be delivered. VSV mode is a safe mode, reliable method, can reasonably be used for weaning. It confers a potential benefit in decreasing weaning duration and shorter ICU length of stay. So I think the major modes we are through with. Akash, are you there?
Yes, sir, I'm here.
So can we go ahead with the vent-trainer simulation scenarios to understand
yes.
all the modes?
Yes, sir. Yes, Sulochana, can you share the screen?
Yeah. Is it visible, sir?
Yeah, it is visible. So we were discussing about the APV SIMV mode. So APV SIMV mode, again, we will go ahead with it and just do the settings of APV SIMV mode, which we had discussed. I think already the settings are there. Right. Now just confirm the settings and start ventilation. So you are seeing over here in APV SIMV mode, there is no spontaneous triggers which are seen over here. Whatever respiratory rate which you have set of 10, the same respiratory rate is being delivered. There are not a single spontaneous effort there. In the monitoring, can we see how many spontaneous efforts are there? Just go to the monitoring. Yeah. So here we are seeing that there are 0 spontaneous efforts over here. 0 spontaneous efforts are there. And the total breaths which we are delivering are 10. Now suppose the same patient has got certain spontaneous efforts which are there. right? So just see what, make this patient active and give certain spontaneous efforts to this patient. So what here you can see over here, we have set a respiratory rate of 10, but the total spontaneous efforts over here are 13. That means the 3 or 4 spontaneous breaths are being taken by the patient. Now, whatever these 3 or 4 spontaneous breaths are being taken, again, go to the control mode. Let's go to the control mode. So the spontaneous breaths which are being, just go to the control and select APSIMB.
APSIMB.
Yeah, just confirm. Right. So these 4 breaths, which are extra breaths, are being taken by the patient himself. Now we have 2 settings over here. One is the VT, that is the tidal volume, which you have set, and the other setting was the pressure support. Just go to the control. Yeah. The other is the pressure support, P support. So what is this P support is? Whenever the patient is taking some amount of breaths, which are the spontaneously triggered breaths by the patient himself, whatever breaths are being supported, they are being supported with the help of this P support to the patient. So this P support is important in the spontaneous triggering of the breath, right? So FIOT you have set, PEEP you have set, tidal volume you have set, rate you have set. Now again, go back to the APV CMV mode. Just select the mode of APV CMV. Right. So you adjust the rate to 1:2, flow trigger is 2.5, FiO2 is 50%, PEEP is 5, tidal volume is 460, and TI 1:2. Let's keep 1:2. Yeah, 1:2.0, right? Okay, just confirm. Rate, increase the rate to 12 at least. So this is a volume targeted ventilation. Everybody is agreeing to it, that it is a volume targeted ventilation, right? Now, in between the spontaneous triggers, we are seeing that there are certain spontaneous triggers which are there. And just make this patient passive. Remove the breaths, just sedate this patient, give some sedation and relaxant and remove the triggers. Go to the patient and just select it. No, just cancel it and go over here.
Controls.
The 3 lines which are here, just go over it. Yeah.
Sorry, yeah.
And just go to the patient, make the patient passive. Right. Just close it. Right. So the patient is not having any inspiratory efforts. Right. Now the same patient, if we decrease the compliance of the lung by, if the patient is having some ventilator associated pneumonia and the compliance goes down, what happens to the peak pressures? Just see, decrease the compliance and see what happens to the tidal volume, what happens to the peak pressures. So you're decreasing the tidal volume. You are seeing that the minute ventilation now gets compromised. The minute ventilation which you have targeted 460 ml of tidal volume, 12 of respiratory rate. The tidal volume has started coming down. The peak pressures have started rising. You have go to your alarm limit and see what was the alarm limit which you have set. You have set an alarm limit of 40. So 10 below that the 30, it is getting cut off and it is giving a low minute ventilation alarm. Now, if the same patient with the same compliance, what is the compliance of this patient? Just see the static compliance. static compliance is being displayed over here. So it is 12.3. What is the end tidal CO2? It is 64 because the minute ventilation is getting compromised. So the end tidal CO2 is on the rise. So the CO2 elimination is getting compromised. Now we want to change it to some other mode. Just select a pressure targeted ventilation for this patient. Just select pressure control mode. Let us see whether this patient, if we ventilate on PCV mode, what happens to him. Just select PCV. Confirm. All right. Let us see what happens. Oh, the tidal volume has started rising. You see, the tidal volume is going to 613. Just go down on the pressure control bit. Just go down on the pressure control. We don't want a 613 ml of tidal volume. So just go down and target a tidal volume of around 7 ml per kg. 6 ml per kg is pretty good. 6 to 7 ml per kg. Yeah. So you are seeing that the same compliance, and when we are ventilating on a pressure control mode, what we are seeing is the tidal volume getting maintained, the peak pressures are coming down. So when we have targeted a pressure, this uniform distribution of pressure occurs along the lungs and thereby preventing the barotrauma. In the volume control mode, what was happening is the ventilator was targeting a fixed tidal volume. The peak pressures, to deliver that pressure, the ventilator was giving all efforts. So the peak pressures were being reached. The alarm limit was set to 40. So at 30, that was a cutoff. So the tidal volume, and the minute you were not able to maintain a minute ventilation, and neither you were able to deliver the tidal volume. As soon as you converted this mode from VCV to PCV mode, that is pressure targeted ventilation, with a mere pressure of 15 centimeters above the peak, you were able to achieve a tidal volume of 368 with the same respiratory rate, which was knocked off, right? So now this was the difference between the volume targeted versus a pressure targeted ventilation. Now we go to the dual control mode, that is the pressure regulated volume cycle mode. So just select, I think, yeah, just select, not dual, select the APV CMV, right? Right. You get the IS2E ratio is to 1:1.5, 1:2. FI to 50%, PEEP of 5, tidal volume 460 ml. Right. Right. So now we are seeing over here, the inspired tidal volume is 455, 454 ml. Total respiratory rate is 12. There are no spontaneous efforts which are there in the patient. Now, since the compliance is gradually improving and the patient is responding to the antibiotics, the compliance starts improving and the patient again starts maintaining his saturation, which is around 100. We go down on the FiO2 and the spontaneous triggers have started coming. So just make this patient again active and go to the spontaneous mode. Just go to the spontaneous mode.
Spontaneous mode.
Patient, and make the patient active. Right. Okay. And right. Go to the spont mode. Go to the spont mode first.
Sir.
In controls, go to the spontaneous mode. Select the mode spontaneous. In modes, go and select the spontaneous.
It's not going up. Yeah. Yes.
Just select spontaneous in the pressure control spontaneous mode. Can you see the spontaneous
Yes.
mode? Yeah, yeah. Just confirm. Confirm. Now in the spontaneous mode, as I have said, that the patient himself takes breaths. We don't decide the breaths of the patient. Go to the controls. So ETS sensitivity, this is deciding the time which is required for the inspiration to be there. So the more you select it, suppose you select it to 30%, that means at the peak, if the peak flow falls to the 30%, the inspiration will be cut off and it will go back to the expiration. Since you have selected it to 25%, the peak flow when comes down to 25%, the inspiration is cut off and expiration starts. If there is a COPD patient and you want to give more time to the expiration, you keep this ETS sensitivity to 30%, 40%. So you cut off the inspiration earlier and give more time for expiration. If you have a type 1 respiratory failure patient, you want to give more time for oxygenation to this patient, just reduce the ETS sensitivity to 15%. So allowing more time for inspiration. Secondly, triggers. So if it is a patient triggered breath, so all breaths are being triggered by the patient. Patient starts an inspiration. There is a difference in the bias flow between the inspiratory and the expiratory limb of around 2.5 liters. And this 2.5 liter is generated and the ventilator senses it, triggers a breath. Now, whatever support you want to give, since you are already getting a 625 ml of expired tidal volume, you want to reduce this pressure support. So we'll go down on this pressure support again by 11. Right, just see. So whenever you are using this mode of ventilation in spontaneous mode, when you are deciding to go down on the pressure support, one variable which you have to see is the rapid shallow breathing index. So where is the rapid shallow breathing index which is displayed here? Just cut this down, cut the screen down and see there is a display of the RSB over here, which is displayed as 80 or 79. So what is we are seeing that the limit is 100 to 10. So if it is going above 100, that means the patient is not ready to get weaned. So it should be between 10 to 100. It is already displayed in the ventilator in the pictorial form as well as in the numerical form. So this is the value over here. Again, a good amount of breath is being delivered. Support is being delivered. So patient is taking a breath, which is expired tidal volume of 344 ml and a total respiratory rate of 28. Now, what do you want to do? Just go back to a case scenario. We will go to a case scenario which is there. And just stop sharing. I'll go to the case scenario. Then we can again come back to the ventricle. Right. This is a 53-year-old male. My screen is visible. I'm audible.
Yes, sir.
Yeah. So this is a 53-year-old male patient who presented with a high-grade fever, cough for almost 1 week. He was admitted to local hospital for a week for essential intervention. He was treated with assumption of viral pneumonitis. After 2 days, he started experiencing shortness of breath and was put on oxygen with non-rebreathing mask at 12 liters per minute. Post 4 hours of non-rebreathing face mask, he was put on NIV with pressure support in view of slight elevation in his respiratory rate. After 12 hours of NIV, he suddenly underwent into severe respiratory distress. On examination, he was tachypnic, having a respiratory rate of 40 breaths per minute. His saturation was dropping to 88% on an FiO2 of 0.7, pressure support of 15 and PEEP of 6. He was electively intubated due to worsening respiratory failure because of hypoxemia and tachypnea and was shifted to higher facility. After arrival at the ICU of the higher facility, systemic examination was done, which revealed these findings. What were the findings? The respiratory system, it is the bilateral creps were present. A provisional diagnosis of viral pneumonitis with ARDS was suspected, and what was done was that X-ray showed bilateral infiltrates with a CT again showing that there are bilateral ground glass opacifications over here. So basically, it is a frank ARDS which has developed. Arterial blood gas was done, ordered immediately at an FiO2 of 100%. Just note down these settings, that is FiO2 of 100%, pressure control settings of 20 centimeters and a saturation of 84%. The pH was 7.10, PaCO2 was 50, PO2 was 49, saturation was 72 and bicarb was 20. Later, the chief intensivist tried to change it to some other mode. That is not the scope at present of this lecture. So this was an ARDS patient. Had you been ventilating this patient on volume control mode, so again we go to the vent trainer mode and vent trainer's scenario. Feed on these settings and see how this patient behaves. This is a frank ARDS patient having a PCO2 of 50, PO2 of 49, saturation of 72. So are we able to ventilate this patient on volume control mode, or we have to change them to some other modes? So let's see. I'll stop sharing again, go and start the vent trainer scenario.
So is my vent trainer app visible?
Yeah. So just target, just put out on the CMV mode and
Patient was a pressure control.
So Rojna, first make it passive patient.
You will have to go back.
Yeah, go to 3 bars and make it passive.
Yeah.
so the patient is passive, having 170 centimeters, 66 kg of ideal body weight, having a low compliance because ARDS is there, so compliance is low. And
You can also select
try
ARDS.
ventilating on VCV mode. Right, Akash?
Yes, sir.
Just select the ARDS condition to be ARDS.
This will happen only on
Yeah, to
standby.
make it standby.
Go to standby. Right. Select a male patient, 170 centimeters.
Yes.
PCB mode. Patient was on pressure.
Just select the CMV mode. We will first see what happens in the CMV mode, then we will change over to the PCB mode.
First cancel that.
Yeah.
So just reduce the tidal volume to 6 ml per kg. It is 8.2. Just reduce it to 6 ml per kg. Right. Introduce a T-pause of, just give a T-pause of 10%. Right. Increase the rate to around 14. Right. Let's see. Let's see what happens. If I have to 100%, since saturation is falling, it was 66, 62%. You can see that when we have selected this volume targeted ventilation, the tidal volume set was around 6 ml per kg, but we are not able to achieve it. Already the peak pressures are around 40 centimeters. The tidal volume which is achieved is hardly 155 ml. Still, if we want to know whether the peak pressures are there, just go to the tools and select an inspiratory hole to check for the plateau pressures.
Just 35.8.
So the plateau pressure is displayed over here in the monitoring. Let's go to the monitoring. Just unpause it and go to the monitoring. Go to the monitoring. Yeah. So what you are seeing? Peak pressures are 40. Again, perform an inspiratory hold to see what are the plateau pressures. Go to the tools, perform an inspiratory pause to look for what is the plateau pressure.
So
What is it? 35.8. So it has already crossed the limit of 30 and it is above 35.8. We can't go down further on this. Already we are on at 6 ml. If we further go down, you are already compromised with the minute ventilation. If we increase the respiratory rate, again the peak pressures are high. We have compromised the inspiratory time. So I am not able to ventilate this patient on the volume control mode. Any other thing which we can do? We can change the mode to pressure targeted ventilation. Just to change the mode to pressure targeted ventilation or just change it to PCV.
Just unfreeze first.
Confirm. Height to 170. Right. Increase the pressure control again further. The PC, increase the PC to 20 and let's see what is happening to the tidal volume. Increase the PEEP as FiO2 is again, SpO2 is 65%. Increase again the PEEP to 10. Right. Let's see what happens. The compliance is 5.5, extremely low compliance is there. Saturation already 65% or 100. FiO2 and PEEP of 10, pressure control of 20, a respiratory rate of 15. Now again the saturation is falling. Any other thing which we can do? In this, through this tool, we may perform a recruitment manual. That is not in this class, but apart from this scope of this class, there is a tool which is known as PV tool. We may perform recruitment manual to see whether this ARDS patient is recruitable or not just by giving a high PEEP. So yeah, somebody has said, can we apply extrinsic PEEP of more than 10 for ARDS patients? We can go on, we can increase the PEEP further, but first we have to titrate what is the actual PEEP which is required. If we see in this ARDS patient, just go to the monitoring and see if there are any esophageal pressures or transpulmonary pressures which are available. Just select the graphs of esophageal and transpulmonary pressures. PES. So you are seeing what is the esophageal pressure of 13.2. We are already giving an extrinsic pressure PEEP of almost 10. Just increase the PEEP more to around 30 and see what happens. Increase the PEEP bit more. Right. So Ritesh is telling that we can try APV CMV mode and target 4 ml per kg with higher rate and paralyze this patient. So patient is already paralyzed. Just switch to AP, as he told, switch to APV CMV mode. APV CMV mode. Right. Confirm. ramp you have set, trigger you have set, FiO2 is 100%, PEEP you have selected of 15, targeted a tidal volume of 390 ml and rate of 15. Just increase the rate to 20 and select an I/E ratio of around 1.1 is to 1.5 or 1 is to 2.
1:2.
Right. Now let's see what happens when we are ventilating in APV CMV mode. So we are seeing that you have set a tidal volume of 390, FiO2 of 100 at a PEEP of 15. The PEEP pressures here are 30. Respiratory rate you have set of 20. Just go to the monitoring and see what all the other parameters are there. You see hardly an expired tidal volume of 146 ml, minute ventilation of 2.9. All the breaths are ventilator triggered, no spontaneous efforts are there. Still, we are not able to achieve a tidal volume of 146, or only 146 ml. So there is again further one step ahead. Intelligent mode, or that is basically an intelligent mode, that is an adaptive support ventilation, which is there in the Hamilton. Reduce the PEEP to 5. So why you want to reduce the PEEP when we have already a saturation of 65%? So reducing the PEEP further to 5 would be disastrous in this patient. As we are seeing, go to the esophageal pressures. Go to the esophageal pressures. So what is the esophageal pressures? Maximum is 17.6. The mean is 17.6 is the esophageal plateau pressures. So there is an intrinsic 17.6 pressure. Extrinsically, you are giving just a 15. If we go for the transpulmonary pressure monitoring in this, there will be a negative deflection in the transpulmonary pressure. Can we display the transpulmonary pressures over here in the waveform?
Try, sir.
Just go to the graphics and select. No, not graphics. In this waveform, just select the transpulmonary pressures. Click on the waveform and select.
No, sir, I don't think so.
Sulochana, click on graphics and the
Okay.
layout one. Close it again. Go to graphics. Now layout one. Yeah, and again click on the volume graph and go to the esophageal waveform.
P transpulmonary. And
PES and the last
esophageal.
second one. Also click on PCO2 and change it to P trans. P trans, which is below the PES.
Below the PES, yeah, selected. So what you are seeing over here, there are two curves which are getting displayed. Just remove this PCO2 curve and display the P esophageal pressures. Yeah. So that's it. Yeah. So what we are seeing is the transpulmonary pressures. Here the transpulmonary pressures means that there is certain pressure which is outside the alveoli, that is the pleural pressure. There is certain amount of PEEP which we are giving inside the alveoli, that is positive end expiratory pressure. One of the participants commented that by giving 15 centimeters, we are harming the alveoli. So how do we know that compliance is just 5.1, and we know that still we have to ventilate this patient? We may receive this patient and we have to ventilate it in the ARDS settings. So what we are targeting here is that whatever the transpulmonary pressures are there, they should be on the positive side. There should not be any negative deflection over here. We have already compromised the minute ventilation. We are not reaching the targets of the minute ventilation. I would suggest you just change this mode to the ASV mode and with the same settings. Change the, just select a mode, ASV, confirm, confirm. Increase the percentage minute ventilation to 125% or rather 150%. Right. Keep the PEEP to 15 and FiO2 to 100. Let's see what is happening. just display the ASV curve also over here. Right. So we will have separate session on ASV. That we know, Akash. We will have a separate session on ASV just to demonstrate that ASV might be a rescue in this scenario. We have switched to ASV mode. Further, inverting the ratio to 2:1, we can adopt a strategy of 2:1 or inverse ratio ventilation. But only thing is, the disadvantage of inverse ratio is that already the CO2 is crossed to 120, I think 250. So inverse ratio ventilation will further add on to the CO2 accumulation. Now going back to the presentation and selecting our further modes. One mode which is left again is the APRV mode. APRV mode is considered an open lung approach. What is APRV mode? APRV is at airway pressure release ventilation. It is a continuous positive airway pressure with an intermittent pressure release phase. What happens is your patient is getting ventilated between the two pressures. One is a P high pressure, one is a P low pressure. The time interval for which this patient has spontaneous efforts at a higher pressure is the T high. Automatically, the P high gets cut off and the patient gets spontaneous efforts at the P low, which is being selected by the patient, by the clinician himself, and at a T low. So what happens is, in APRV, there is a CPAP P high for a prolonged time of T high to maintain an adequate lung volume and alveolar recruitment. So whenever you are ventilating at a P high for a time interval of T high, you are performing a recruitment. You are trying to give alveolar recruitment with a time cycle release. After a particular interval of T high, there will be a T low of short period and a lower set pressure of P low, where most of the ventilation and CO2 which is accumulated gets removed. So the CO2 gets removed, the CO2 gets washed out. So intermittent release ventilation is also happening in this. So we are having two features. One is of the recruitment, which is happening at a P high and a T high, and inverse the release of the CO2 at a T low and a P low. So these are the settings which are there: P low 0, P high of 25, T low of 0.6, T high of 5.4 seconds. So obviously T high is higher, that is 5.4, and T low is 0.6. So we are ventilating at a much more time at a P high as compared to the P low. Right. So this is what is the display screen of the APRV, in which there are T low, P high, P low, and FiO2. So the patient gets ventilated and recruited at a P high. Then there is a CO2 which is getting accumulated. So at T low and P low, the CO2 gets washed out. Advantage: APRV is considered an open lung approach. The concept is of maximizing and maintaining alveolar recruitment. What we are seeing is the alveolar recruitment is occurring at the P high pressure. Preservation of spontaneous unassisted ventilation throughout the entire ventilatory cycle, because the patient is having spontaneous efforts even at the P high and at P low, maintaining a relatively long inflation time, so that it is a potentially lung protective benefit. Again, DOPAP is a new respiratory support mode consisting of combination of two CPAP levels. The DOPAP is same as BiPAP. It is a pressure control BiPAP for invasive purpose. Whatever BiPAP you are applying in a non-invasive, with a PC integration in the BiPAP, it goes for an invasive purpose. So this is regarding the case scenario, which we discussed, that ARDS ventilation, we were finding it very difficult ventilating on VCV mode. We tried seeing the esophageal pressures and the transpulmonary pressures, titrating the PEEP. So PEEP was increased to 15, still the recruitment was not there. We changed it to a further advanced mode, which was ASV mode, which will be discussed further in the future in the subsequent lectures, why we adopted to the adaptive support ventilation. So the gist of this lecture was that no matter what mode you select, you should know the advantages and disadvantages of these modes. Basically, the volume targeted ventilation and the pressure targeted ventilation each has its own advantage and disadvantage, which we discussed. And the dual modes, the hybrid modes, that is the pressure regulated volume cycled mode, which is a volume targeted and a pressure control mode, are relatively safe modes in which we find ventilating these patients which are quite difficult to ventilate. Also synonymous with the auto flow or adaptive pressure ventilation. The flow, these are all the basic modes which we have discussed today. Akash, any case scenario which is left or any modes which we have left today?
I think no, sir. We have completed so far everything.
Right.
Sulochana, you have to add anything? I think we have few questions in the chat box. There was one question which someone asked. What is ETS?
ETS is the expiratory time of sensitivity. And now what we are, as I already explained, that in the spontaneous mode, there is a certain amount of peak flow which is achieved. After the peak flow which has being achieved, there is a decrease in the flow. When this flow comes and achieves a particular level, what we have set, suppose the peak flow has come to 25% of the whatever the flow, peak flow was there, the inspiration gets cut off and expiratory valve opens and the expiration starts. So that is the sensitivity at which you want your ventilator to cut off the inspiration and start the expiration, especially in the spontaneous mode. So we have selected an ETS, placed an ETS over there. As I told you that in COPD patients, if the COPD patients, we need more time for expiration to be there, and relatively less time for inspiration is a prolonged expiration. We want to give more time for expiration. So we want to cut off the inspiration earlier. So we keep an ET sensitivity higher. That is, we want to cut off it at 30% or 40% of the peak flow and start the expiration earlier. So to give more time for expiration. So basically, APRV is a weaning mode. DOPAP mode, it is similar to a BiPAP mode, which we are using in the NIV. Only integration is of the pressure control in it. Rather than that, APRV mode has got further evidences in the recruitment of the patient. So we continue with the spontaneous efforts at a P high. So the alveolar recruitment occurs over there. As soon as we go to the P low at a time interval of T low, the CO2 is released. So our relatively more timing is being depicted, and more timing is being delivered for the P high for the recruitment. And as soon as the CO2 starts accumulating, we come down to the P low at a time interval for T low so that the CO2 gets washed out. Whereas in the DOPAP or BiPAP mode, it is simply a BiPAP mode, which is the patient is being ventilated between the two pressures with a pressure control setting, that is BiPAP in the invasive mode.
So candidates want to see when APRV mode on vent trainer. So
yeah, just share the vent trainer screen. Yeah. Confirm. Just select the P low to 0. Go to the controls. Right. So just keep the P high to 25. Right. Okay. Just go down bit on T high. T high.
right. Want to keep it 2 seconds?
No, it is pretty good. 3.5 is pretty good. Let's see. So there is a P high, there is a P low. The time for which the patient is being ventilated at a P high is the T high. The time at which it is at low is the T low. Now, whenever the patient is getting ventilated, just make this patient having certain amount of ventilation. Yeah. So it is giving IRV. Why? Because the patient is not having any inspiratory effort. So P high is definitely the time for T high is more as compared to T low. So it is giving an alarm of TO. Now that is P and tidal CO2 is high. So we just go down again on T high and increase bit at T low. Just go to the again to the controls. Go down on TI and just increase bit or T low.
But decrease the T high.
Yeah, just decrease the time for TI and increase the time for T low.
Select respiratory.
Just increase the compliance of the patient. Now.
So it's that.
You are seeing that the SpO2 is presently at 80%. Compliance is 9.9 ml. Yeah.
Not be increased because it's going.
Just go to the patient and increase on the 3 lines. Select normal condition and select it to continue.
Hi, sir. Stanford.
You have to start on normal conditions, right? Go to, go to 3 bar.
Yeah.
And change it to
Patients.
Patients and change it to the standard condition. Standard condition.
Yeah.
Yeah.
This remains passive.
Okay, make the patient active.
You can make it active also.
Yes.
It's not.
Right now, it is
But
only
it's
for the
currently on.
patient.
Yeah.
Will come in
Just close it.
in the subsequent updates.
Yeah.
Okay. Should I start ventilation?
Start ventilation. Right. So what you are seeing is the T high is the alveoli is getting recruited with this amount of tidal volume. Just go down on P high, make it 18. Right. Let's see what is the change. You see the CO2 is getting washed out, SpO2 is 100%. You perform a sort of recruitment, and whatever the time the T low is being given, that is being utilized for washing out the CO2. This is regarding the APRV, right? Any other mode which we have left? Just select the modes and see any mode which we have left. Yeah. So PCV we have discussed, PCV plus, spontaneous, APV, APS, and CMV. Just select DOPAC. One of the participants had asked about DOPAC. Yeah. Confirm. So basically you are selecting a respiratory rate in this, a P high, P So between the two pressures, time for which that will be in the P high, you have selected a respiratory rate, select some certain amount of PEEP. It is basically between the two pressures in which the patient will get ventilated.
Shall I make it 5, 6?
Yeah, 6. Just make it 6. Just go down on P high to around 14. Right. Select. So you see what is happening between the two pressures. You've been getting ventilated at a respiratory rate of 20 or almost 1 second of the higher pressure limit, that is P high, which is being there. So this is the basic difference between the DOPAP and the APRV. In APRV, you are not setting the rate, you are just setting the T high and T low, the P high and P low, and the patient is getting ventilated as he is already having his own spontaneous effort. If not there, maybe in the controlled breaths also at P high and P low, at T high and T low. Whereas in DOPAP, you are setting a respiratory rate, you are setting a P high, you are setting a P low, that is PEEP and FiO2. And in between these two pressures, the patient gets ventilated. This is DOPAP, right? So any other mode, just select the mode and see whether we have not left any mode. APRV we have done. ASV and entirely ASV, as Akash said, we will be discussing in the further advanced modes. NIV and NIVST, I think they were out of the scope of this lecture. We were discussing about the invasive ventilation. So this completes our target about the volume controlled adaptive modes, pressure controlled adaptive and biphasic modes. These were the basic modes of mechanical ventilation, which you should know and understand. This was an attempt to teach you about the basic modes of mechanical ventilation. Right.
So I think we have come to the end of the session, and I've seen that there are no questions anymore. And in case if you have any questions, we can also take it later, or you can message us also personally. The questions we'll be happy to answer.
Thank you, Akash. And thank you, Solution.
Solution, anything you want to add? Do you want to give a last, closing remarks?
Yeah, I think the session was pretty clear and it was very crisp. And with hands-on training session, I think it was more effective for the candidates because it was not like monotonous. So I feel if candidates can reach out to us, if they have any questions, they can ask us anytime. And I think we'll be submitting them feedback form. So
Yes, yes. So,
yeah.
so we will
So
we'll be
if they
sharing them a small feedback form. Post that, we will also be giving them the certificate of participation. Along with that, we will be also sharing with you the link for this Vent Trainer app, where you can also learn about ventilation in your phone, in your laptop, at your comfortable place. I think with this, we have come to the end of the session. I once again thank Rishi sir, IARC, from IARC, Dr. Swami, and of course Hamilton, to have this opportunity to host this webinar. And looking forward to see you for the for session 2 of the webinar, which includes monitoring and advanced troubleshooting, and the link for which will be shared to you soon. And just a small apology for today, because we had participation limit till 100 for Zoom, and for that we had to share the link for the YouTube. But then in the next session, we'll be of course sharing the or maybe increasing our participation list. In terms of Zoom, so we will have more participation. Just to end, we saw that there were 100 candidates, and I think till end it was 100 candidates maintained consistently. So I would say, sir, whatever you had given, I think each one of us was, very interestingly listening to what you have delivered today. So once again, thank you very much, sir.
Thank you so much. Thank you. It was a pleasure teaching you all, and looking forward further to have such session. Vent Trainer is really very interactive, and we can use this Vent Trainer app to learn and create your own case scenarios and see what all changes occur in the ventilatory parameters. And it is really the simulation part of the Ventrainer app is really helping to learn a lot. So Ventrainer app is really a boon for those who are learning the ventilatory settings and ventilatory apps. Thank you, Akash.
Thank you, and thank you, everyone. Yeah. With this, we end the session. Thank you.
So, thank you, everyone.